morning, good afternoon, good evening. It's The Search. And look who we've got back. We've got Nikki Taylor back. Hey, Nick.
Hiya! Hello, everybody.
Goodness me, it's a wee while since we've seen you. What's been happening in your world?
Um, well, it's been rather boring because I've just been trying to write up my PhD, to be honest.
Well, as soon as you are our Dr. Taylor, we'll definitely do an episode on that. That is for sure. Thank you for everybody who's joined us today. We're actually going to do a whole episode on critical reasoning. It's something that many of you have requested for us to go through in some detail, and also to kind of apply it in many of the roles that you're applying for, particularly in healthcare and in some of the more interesting and different sort of avenues that come off being a clinician. It's certainly something in occupational health I know that they use a great deal, and certainly in functional assessing. So, Nikki, for you, when I talk about critical reasoning, for you, what kind of springs to mind for you?
Well, I guess if you were just to ask me off cuff, I'd go, "Oh, what are you talking about?" If I'm being honest, really. Because I think it's something that as a clinician, you probably do often, in fact, every day, but you might not always label it as critical reasoning.
Hmm.
I always just kind of think of it in terms of being nosy, being inquisitive, and just trying to put the pieces of a jigsaw together so that they make sense, if that makes
Sense.
any sense.
Yeah, absolutely. Absolutely. I remember, and this is like ancient history, Nikki. I remember when I was a very young clinician being told that how to weigh up information is to make sure that you're reading and that you're reflecting and that you're observing, and not to give too much weight to any single one. And that
Absolutely.
and that critical reasoning is that kind of Venn diagram where those kind of three things come together. That little overlap, that's critical reasoning from a perspective of applying it into clinical practice. Does that kind of resonate with you?
Yeah, it's that for me, it's that little bit about why and why not and how does this all fit together? And
Mm,
as you say, it's about that balance of, well, they're saying that, but that doesn't quite add up. Um, but I think when you use the term critical reasoning, it kind of throws lots of people.
yeah.
Um, and also I think sometimes, as I said, I think it's something that we do intuitively as clinicians because
Mm,
it's
mm.
something that is so embedded in our practice. You just kind of have that almost like that antennae of that don't make sense. You know
Yeah,
what
yeah.
what's going on here? And as you say, that bit of being a reflective practitioner, of actually knowing the evidence and then seeing what's in front of you and thinking, no, that just doesn't make sense. What's going on here? That I think
Mm.
for me is the kind of fundamentals of it all.
Yeah, again, Nikki, I'm a little like you. I'm somebody who pictures a lot in my mind, and so when you used to get admissions from A&E or planned admissions onto a unit, and you would read what's coming up. So you would get the transfer documentation and you would get the age diagnosis, what this person's coming with, and you'd paint that sort of picture. And then somebody else would come in and you'd think, can I just check your name back that you're the same person? Because the evidence that I've got and actually you as you're presenting is two different things. Can I now, as you say, use my clinical nosiness to kind of go, I was expecting this. Can you just tell me a little bit more about it? And I think that's something that is so reflective and so every place in common sort of day for clinicians that, as you say, actually putting a label on it makes it sound like it's something far more important than it really is. And I suppose one of the big things that we have as clinicians is around having that, particularly when we're in interviews, because of course we're talking about, we're recruiters and we're talking about being in interviews and those sorts of things. When we have a question, when they say, well, I'm just going to probe into your critical reasoning, I genuinely think we're all like, number one, what is that? And number two, I wouldn't even know where to start, from a question, from either understanding the concept or being able to answer the question. So for you, Nikki, have you got any tips or hints for anybody who's thinking, right, okay, they're going to ask me a question about this. What's the Babel fish? What's the translation for that?
Yeah, I always think of it in terms of you talked about the kind of Venn diagram. I always think about it in terms of a triangle and the points on a triangle. So what is the person saying to me? So I've got a patient in front of me who's telling me that they're in loads of pain. That's what they're telling me. But what am I observing? What am I sensing? What's actually in front of me? Does that person look like they're in agony? Are they bending over? Do they look uncomfortable? Do their verbal and their non-verbal actually fit together? So does that side of the triangle fit together? And then what does their medications suggest? Are they on regular medication? Well, no, they've not taken any medication at all. So they could be, they're asking for diamorphine, for example. Well, does it all fit together? Is it a clinical picture that this person is in physical pain? Or do I just go and give them diamorphine because it's prescribed? Or do I use my kind of inquisition about, well, what's really going on here? And actually it's not the right pick. It's not the right pick. It's not the right intervention to be making at that point in time. Does that make sense? That kind of 100%. Triangle, clinical knowledge, what's in front of you and what the person's saying, and you kind of identification of what the problem is.
Absolutely. And I think sometimes what's often difficult as a clinician, and I think this is what makes being a clinician really interesting, is fluctuating conditions. I think they're I used to hate them when I was a junior clinician. I'd be like, oh dear God, I've just got my head round acute and I've just got my head round rehabilitation. Fluctuation, oh, you're kidding me. That's just, how do I work with that? And I think as you get more confident as a clinician, complexity is something that actually makes your tail wag, doesn't it? And I think for me, trying to think about critical reasoning when you've got fluctuating conditions is often a difficult one. And I think, when we think about any fluctuating condition, either it's physical health or mental health, understanding how to apply critical reasoning to a good day and how to apply it to a bad day, and actually how to apply it to an in-between day is I think where the art and the science comes in, don't you?
Yeah, and I think it's very different, isn't it, to giving an example of when you're in practice, as I've just done, when you're trying to weigh up whether somebody would take some medication or whether you would give them some medication or not, to actually, as you say, when you're maybe in a role that is, as an assessor's role would be, one where you're trying to ascertain, what a good day and a bad day looks like and where they are on that kind of continuum. That's very different, isn't it, to how you can articulate that translation and transposition of those skills that you've got in that very clinical environment into an environment where you're doing an assessment as part of a work-based intervention or work-based kind of assessment as you would do as an occupational health nurse or as a functional assessor. And actually, you know, you're going to then use that evidence to write a report. So taking those basic skills that we've all got and then using them in that different setting, I think, is quite a leap. So I'm not surprised that quite often people get get startled by those kind of critical reasoning questions.
Yeah, I have to say I would too. So I think some of the particularly when we are functional based, occupational health based, when you're looking at one of the more common activities of daily living that can fluctuate is mobility, isn't it? In many cases, and certainly impacted by long term conditions. And looking at, for me, if we go back to the Venn diagram or the triangle, I don't really mind what one you use. It's whatever works for you. And looking at sort of the evidence that you have around, we all know about mobility. It's the more you are mobile, the more mobile you become. Yeah. So being able to use mobility, even in a restricted way, is better than not being mobile at all. And what support have you got in that? And you can have evidence from things like, physiotherapists, GPs, occupational therapists are fantastic with that type of mobility and adaptation. And then looking at what someone tells you about their mobility, how they find getting around, how they use things like public transport, how they do manage on really basic tasks like, how do you get to the shops? How do you, if you have to go and see the GP and you're saying you're seeing them quite often, how do you actually get there? And sort of going into that help me understand how this impacts you. If this is something that has a flare, and in those flare times, particularly I'm thinking about, when somebody has maybe, really acute back pain, and they are, in a sense, really quite immobilized by their back pain. And when they have an episode, they're completely immobile. How do they manage? And then as they're recovering, how do they manage? And then what does good look like? And then sort of getting a sort of idea of things such as what other interventions do they have? Are they seeing the GP? Are they seeing other health professionals? And equally, are they using non-traditionals? Are they going to yoga? Is that actually the best thing for their back pain? Is actually going to Pilates the best thing for their back pain and keeps them mobile? And so it is around not just looking at that traditional evidence, but certainly looking at some of the social evidence around it as well, I think helps put that back together.
And I think also sometimes it's about identifying when there might be some discrepancy. So they might, be saying, "Well, I can't go to work, or I can't do this," but then they'll drop into the conversation that they've, been to the football, or they actually go out for to the theatre or to the cinema in your conversation, and it's just trying to work out when that is that when you're good, or is that all of the time, so that you're just trying to get that holistic picture and really understanding what the good day looks like and what the worst day looks like on that continuum.
Yeah. And then, as we said, sort of using that reflective, I think as clinicians, what makes us good clinicians is that we're naturally quite empathetic. Yeah. And looking at emotionally taking that, not discarding it, but putting it to one side and then coming back to what does the evidence say. And I think that's where you have that sort of critical reasoning. So you're taking all of that evidence and you're looking, as you say, at patterns. Is it, well, actually, I go to the cinema 4 times a week because actually that really motivates me. But what I have to do is when I'm in the cinema is that I get somebody to take me to the cinema. I actually can't sit. So I stand at the back. The people in the cinema know that. So, it might look like I'm a bit of a weirdo walking around, but actually that's how I manage in there. So it is around looking at that context of evidence and then applying it into that person, isn't it?
And I think that's a really important point, because it's about not making assumptions, isn't it? So just because somebody
Yeah,
hasn't put down that they're not on any medication, and you think, oh, well, they're obviously not in that much pain, actually asking them, because they may have just forgotten, or they may be on something that they don't consider to be a painkiller, like amitriptyline, so there's lots of things. So I think added into that, triangle, or that Venn diagram, is that sense of just making sure that you're not making any assumptions about what is being said or not said.
absolutely. And you'll know, Nikki, from your experience in pain management and working within pain clinics, and certainly in my experience of working, quite a lot with chronic patients, some patients actually don't take pharmaceutical medication. They don't. They actually prefer to use something else. So they might be using a TENS machine. They might be using other things. So just relying on one source of, is it a pharmaceutical that's managing that? It's actually, as you say, getting more evidence into, because somebody uses a non-traditional method, it doesn't mean that that's not what's managing their pain, or that they're in that amount of pain. It is around how it impacts them in that wider context.
Yeah, absolutely. Or it could be, that they've tried different medications, and actually the iatrogenic effects of them, the kind of side effects of the medications, mean that actually they prefer to live with the pain, because the side effects are far worse and the painkillers don't take the pain away properly. So, as you say, it is getting that whole picture and really digging underneath to find out what's really going on for them.
Absolutely. And then in that case, when you are putting together your triangle or your Venn diagram of not just looking at what that person is saying initially, asking those follow up questions, looking at what evidence that you've got and what source you're relying on. You might find that you may give more weight to some evidence than you would to others. So if you maybe had a letter from somebody's yoga teacher versus a letter from someone's GP, you may well give a little bit more weight to the GP letter, just because that's something where that they've written those sorts of letters before, and that they've got, as they will provide evidence. I'm not discarding yoga for everybody, please don't take it the wrong way, but there are some evidence that you will give a lot more weight to. If you've got a letter from Pain Clinic, for example, you may actually give that more weight to the GP letter, just because they're a specialist in pain. So again, it is using that critical reasoning on sort of a hierarchy of evidence as well. Is that a fair sort of comment to make? So if I was to give you a question in an interview, that say somebody has presented that they are in 10 out of 10 pain, letter from the GP is that they're on no pharmaceuticals. Yeah, they're not attending anybody. There's no history of trauma. There's no history of any intervention around this. Let's give it back pain. What sort of further evidence would you be looking for, Nikki?
Well, I guess, again, it would depend upon, circumstances, but I'd look at things like observation. So, how did they walk into the room? How did they actually sit themselves down? What am I seeing in front of me? Does that look like that they're actually in pain? So I'd be using my observational skills. Obviously, I'd be asking them to tell me about what makes their pain worse or better. I'd actually be saying to them, I noticed that you're not on any medication. Can you explain why that is, and help me understand what makes your pain better, and how you are managing it? What other things do you actually use? As you said, it might be that they're using a TENS machine. They might have the TENS machine on them for all we know. They might actually be using acupuncture. But actually, it's about, as you said, finding that out. But it could be that you look at all of those things and you think, it doesn't make sense. It can't be a 10 out of 10. They might have back pain. I'm not doubting that.
Mm.
But actually, this isn't a 10 out of 10. This person can move, they can sit down, you know, they're not using anything else. They said that they put a heat pad on it occasionally, but there's no real evidence to suggest that this person is in a 10 out of 10 back pain. So I think in that case, you know, you would question the kind of using that kind of critical reasoning. You would suggest that actually, although the person says that it is 10 out of 10, there is no significant evidence to support that assessment that they are making. You know, you're not saying that they're not saying it, because they are, but actually you haven't got any evidence to support that.
Yeah, I think that's you know, a really sort of nice way of, you know, within an interview. So just to wrap up for everybody, number one, don't freak out if somebody asks you about critical reasoning, because it's an everyday thing we do every day. Yeah. So, you know, please, number one, don't freak out. Number two, you've got two little tools there. You can either have your triangle, beautifully explained, Nikki, or you can have your Venn diagram. You can tell who's the easier person, who's got the easier things to draw, and then and then, you know, how to articulate that in a way that you can get across that there's hierarchy of evidence. You know, you're using all of the different tools that you've got, you pull all of that together, and it's not a subjective, you know, you're not denying that this is what the person's saying. It's actually the evidence to support that just, you know, isn't there. Yeah. And that's how we would suggest that you answer those. So thank you, Nikki. It has been a pleasure, never a chore, to see you. We are on YouTube, so please subscribe down there, because if we don't say it, then our team get a bit upset. Follow us on all the socials. We've got Instagram with Top Tips Tuesday, which gets funnier every week, let me tell you. We are on all of the others, TikTok. We're on Facebook. Please do give us a mention, give us a click, give us a review, and you know, we will look forward to coming back and seeing you all soon.